Okay, so we have Alex, Shay, Casey, Tara, Michelle. That's it. Okay. And we have here Natalie and okay. Should we stop recording? Hey guys, how's everything? Everything is okay? Do you have questions or something like that before we start?
Nope.
Okay. Michelle, you're doing okay? Maybe she is.
I'm sorry, you can start recording.
Doing okay.
All right. Should we start or what?
Yeah.
Okay, guys. Good afternoon, everyone, again. I think we're gonna talk about a couple topics. Let's make it interactive. In other words, if you have questions, you can actually ask um, while we're talking. So we're gonna talk about diuretics, and diuretics. They have two important kind of treatment options. Our number one is the management of fluids in heart failure, and the other part is management of hypertension. We really don't use them much in the management of hypertension, but always remember that diuretics also work as medications for hypertension. That diuretics work in a simple way by getting rid of sodium, right? And I tell my patients sodium is a heavy molecule. It needs a lot of work between the heart and the kidneys to get rid of it. American diet has a lot of salt in it, has a lot of sodium in it. So you have to have some kind of help by medication, especially when you have some component of chronic kidney disease or congestive heart failure, HFpEF or HFrEF. So the diuretics, we have different kinds. We have thiazide diuretics, and they work on the proximal tubules. And the thiazide diuretics, they are mainly used for hypertension management, mainly. We have chlorthalidone and hydrochlorothiazide. And both of these two medications, they really need to have good GFR to work. In other words, if your creatinine above 1.5 or 2, these medications are not going to work because these medications, they need to go inside the tubule to work inside the tubule. So if your GFR filtration rate is very low, you're not going to have enough concentration of medication in the tubule, and the medication is not going to work. So if you have somebody with creatinine of 2, and you want to use diuretics, I'm sorry, and you want to use the hypertension medication, you really need to be careful about using hydrochlorothiazide or chlorthalidone. The other one is the metolazone. Metolazone has nothing to do with the GFR, and metolazone can be used at any kind of kidney failure rate. Metolazone is extremely powerful diuretic, and metolazone can be helpful, especially when you're using different diuretic mechanisms, such as the loop recorders. I'm sorry, such as the loop diuretics, or if you're using the aldosterone inhibitors, and you're going to combine with another medication to increase effectiveness of your diuresis, so you can add metolazone. I always teach that you can use metolazone every like maybe every other day, or something like that, or a couple times a week, or once a week sometimes, or as needed, uh, to be added to your loop diuretics. So metolazone has a very good value in heart failure patients, especially when you are using loop diuretics such as Lasix or Bumix, and you really need to have some more effect, especially in advanced heart failure, HFrEF or HFpEF. So that just keep that in your mind. If your patient is very volume overloaded, so you can use it once a day, 2.5 once a day, or 5 milligram once a day for a week, and then reassess. Or you can use it 5 milligram every other day, or you can reassess. And then down the road, you can just use a couple times a week, or every other day, or once a week, or as needed. Just keep that in your mind. You can use it 2.5 once a day, or 5 milligram once a day. Always remember, when you are planning to shift a lot of fluids from inside the body to outside, you have to check blood work to make sure that your electrolytes are fine and to make sure that your BUN and creatinine is good. Since I'm talking about that, I'm going to mention one thing.
Can I get your phone?
When you're when you're talking about you start having hypovolemia from using diuresis, or kidney injury from using diuresis, the first sign is elevation in your BUN. So when you start having BUN elevation, then you have to start think about, are you in cardiorenal syndrome? Do you have to back off a little bit, and so forth? And it becomes an art of medicine when your patient is volume overloaded, patient continues to be volume overloaded, in spite of elevation. In that case, that's going to be bad luck. Why is it going to be bad luck? Because some of these patients, the only way to do it is by IV diuresis or by albumin to be added, and management at the hospital. But be aware of the fact that when your BUN becomes like 80, 90, and 100, you have to really think about your diuresis strategy. So you're really having pre-renal kind of acute kidney injury, and that might be bad because all of a sudden, and really overnight, you're going to have potassium jumping from 3.5 to 5.5, and then you're going to be hospitalized. So always remember that. Now, the loop diuretics, you have the Lasix, you have the Bumix, bumetanide, and you have the torsemide or Demodex. There's something called one medication called ethacrenic acid. Is very expensive. It doesn't have sulfa in it if you have sulfa allergy, but I've used it once in my lifetime. Very expensive. So the Lasix is easy. The bioavailability of Lasix is about 50%. In other words, 20 milligram of Lasix IV equals 40 milligram of Lasix PO. But the issue with Lasix is absorption maybe varies between patients, and it's not very dependent on in terms of dose when it comes to PO dose of Lasix. So some patients, the 40 milligram works very well. Some patients, the 40 milligram doesn't work. Some patients, you got to do 80 milligrams. Some patients, you really, no matter how much Lasix you use, is not going to work. So in that case, you have to be careful about continuation of Lasix, and you may need to switch to different medication. So now if I say the 20 milligram, let's say 40 milligram PO Lasix equals 20 milligram IV Lasix. The 40 milligram PO Lasix equals 1 milligram PO Bumix. And the 20 milligram of torsemide PO equals 40 milligram of Lasix. So the 20 milligram of PO torsemide equals 20 milligram of IV Lasix. This is the way you need to think about it. So 40-21, so 40 Lasix, 20 torsemide, 1 milligram of Bumix. Now, the way I see it is Bumix is probably the strongest when it comes, and the more predictable in terms of dosing, especially PO, when it comes to PO medication. So if your patient is really not being responsive very well to Lasix, or been on Lasix for a while and now they start having issues, then it's probably time for you to switch to torsemide or Bumix. And the Bumix IV is also very powerful medication. Now it's very ideal to, and especially advanced heart failure patients, it's very difficult to manage their volume, to have a combination of a little bit of loop diuretics, Lasix, Bumix, or torsemide, and metolazone a little bit. The other one that I have to talk about is aldosterone inhibitors, which is spironolactone and eplerenone. The difference between spironolactone and eplerenone is much more expensive, or a little bit more expensive, but it does not cause gynecomastia in men. Spironolactone, it does cause gynecomastia, and the same bioavailability and the same work almost between both of them. You can start at 25 or 50 milligram. You have to check per guidelines. You have to check kidney function and chem panel, creatinine, and potassium, because they are potassium sparing medications within 1 to 2 weeks. I happen to see about 4 patients that the potassium really jumped from like normal to 5.5, one of them 6.3, one of them 6.6 actually. So you have to be very careful. And if you miss that, that's against the guidelines, that's a lawsuit. You'll be really liable because it's written in the guidelines. Now, I would be very careful to use it if your creatinine above 2.5 in men and about 2 in women. However, I've been using it in chronic kidney disease patients. I've been using it in patients with end-stage kidney disease on dialysis. You just need to be mindful about potassium, and you need to be mindful as well about checking kidney function, especially in the first couple of weeks of using the medication. Combination of these medications with loop diuretics or with thiazides is reasonable to do, and they are extremely good, powerful medications. In fact, if you look at the guidelines, you have 2 medications that kind of GDMT for HFpEF. Number 1 is SGLT2 inhibitors such as Farxiga or Jardiance, and number 2 is really spironolactone or aldosterone inhibitors. When they did the study for these medications for HFpEF patients, in the study they found actually if you exclude patients that they were in Eastern Europe, they found that the study was very positive in terms of mortality and decreasing heart failure readmissions to the hospital. When they actually studied the Eastern European patients, especially in Georgia and in Russia, they found that these patients actually were included in the study without heart failure just to gain some money from the study. And I'm not sure how ethical this kind of behavior in Eastern Europe, but certainly there's some value for these medications, HFpEF, and I do encourage any one of you to use these medications if you feel that your patient's hypertension is not well controlled, lower extremity edema that you have to use besides Lasix and so forth. And as long as you have good or acceptable kidney function, and as long as you have blood pressure to manage, as long as you can check chem panel within a couple of weeks of starting this medication. Okay.
Did you say the loop diuretics and aldosterone? Which 2 medications?
Loop diuretics?
No, which 2 medications you were talking about for the HFpEF?
Yeah. Spironolactone, eplerenone, and SGLT2 inhibitors such as Farxiga or Jardiance
Okay.
are the 2 medications.
Okay.
And if you look at the HFpEF, also you gotta look at the whole patient. You gotta be careful about hypertensive management. If they have AFib, the AFib needs to be controlled. If they have sleep apnea, if they have obesity, if they have diabetes, is just this, the whole syndrome needs to be targeted. But in terms of diuresis and blood pressure management and GDMT medications, they are the SGLT2 inhibitors and aldosterone inhibitors.
Okay. Now, can a patient be on loop diuretic and thiazide at the same time for any reason?
Sure.
Okay.
If you look, some elderly physicians, they study one journal every decade. They may be against it, but no, it's actually absolutely reasonable.
Now, is which one would you prefer to use on CKD patient like stage 2 or 3?
For loop diuretics,
Yes.
yeah, you can use any of them. You can do Bumex, Lasix, or torsemide. Any of them.
Okay.
I don't know. I've seen some nephrologists like to use the Bumex, but I mean, it's debatable, really. There's no really study to either or.
Okay.
Any other questions about this?
Fred, I did have one question, and that was about the timing of metolazone and loop diuretics. I've read some that they talk about timing it half an hour to an hour prior if it's oral. Does it really make a difference?
No, it
Okay.
doesn't. No, it doesn't. I mean, I don't know. It's really very difficult to change the pharmacy kind of literature and the way they look at the stuff. It's in really our hands. And I'll tell you this, you know, it's half of what we do is just really not FDA labeled stuff. So you can do whatever you want. Even they say I was talking about the thyroid medications. They have to be taken on empty stomach, right? Until my wife, who's pediatric endocrinologist, told me, no, we give it in the formula all the time. So who cares? I mean, my point is I'm not sure how much interaction, variations, and stuff like that is really hold in clinical
Mhm.
trials. And I'll give you example. I did a bunch of studies and stuff when I was in training about, if you remember, Plavix and omeprazole. Do you remember that?
Yeah. Oh, yeah.
You're my age, Alex.
Yeah, I'm there. I remember it. It was a big deal.
Remember that?
Yeah.
And actually, in vitro, it does affect the bioavailability of Plavix and omeprazole if you combine both of them. But in clinical trials, it never did. And when they did post hoc analysis, never showed any kind of benefit. This is why the FDA removed all this of that label.
Got it.
You ask some of these old physicians, they will probably think it's, oh yeah, man, you can't combine both of them at the same time. But you know, it just fell out of practice since I think 2014, 2015.
Yeah.
So a lot of stuff that I don't think it's look, I mean, you can't just patients are not robots. In other words, patients, they want to live their life. I want to take my medication at 7 and move on with my life. So I'm not gonna after half an hour and it doesn't really make sense.
Okay, thanks.
Any other questions? All right. Tara, you have a question for me. I'm like Donald Trump. I can't read very long messages though. So can you tell us about your patient? Is Tara with us?
Yes, I am. I'm sorry.
Remind me about your patient. Tell everybody about your patient. Let's chat about that.
Yes, sir. 2 seconds. I want to be sure. I can't tell you exactly which patient it was. Hang on.
Did you send me email?
I was going to say, I have an email here. Yes, sir.
You can read it.
Yeah, let me see. Okay, yeah. So, well, maybe. Okay. Patient had a PPM placed in February of 22 with sick sinus syndrome, but also has longstanding, had a Watchman placed and with a recent CVA, and the TEE was indicating a layered thrombus about the occluder device. So she was now placed back on Eliquis. She was recently admitted inpatient with a right V lead failure and had a new leadless, it's actually fractured, the lead was, but a new leadless pacer was placed while she was inpatient. Most recent EKG was A-pace V-sensing rhythm. Well, she came to the SNF for skilled rehab, and we did a pacer interrogation with the report showing the 2022 insertion date, and she was in like just persistent AFib. And so my first question for you was, is that normal protocol? Like, I had a patient with a new pacemaker placed, but yet an interrogation that's reading the old pacemaker. The second question was, well, now that she's back on Eliquis with this clot burden about the occluder device, how long would we continue that? And it was kind of a two-part question. Like, she's chronically in AFib, but has the Watchman, but got the clot. So basically, what do you do in that scenario? But let's say she didn't have AFib, but she only had the clot. What would you do for anticoagulation lengthwise in that patient? Does that make sense? My question, did it come out right?
Yep. So basically, you have
Okay.
a patient who has a Watchman and and had stroke, and they found that there's a clot on the Watchman itself, so they decided that you have to be on anticoagulation, right? Now, look, AFib stroke risk comes from the left atrial appendage. Okay, so the AFib has really the recurrence of atrial fibrillation, the burden of AFib has nothing to do anymore with what we're talking about. That's an issue. She's labeled with it. She's going to continue to have it regardless of how frequent the AFib is going to come. Now we're dealing with the left atrial appendage occluder device that it has a clot on it. Now, if there's a contraindication, this is what I would do. If there's a contraindication to the relative contraindication, let's say, about for the anticoagulation, and we have to think about stopping it, then we have to take this patient and see if there's for TEE and see if there's still a thrombus on the device itself or not. If there's thrombus, we're going to continue to take the anticoagulation. If there's no thrombus, then we can't stop anticoagulation. So it's really has something to do with the left atrial appendage occluder device. There are two kinds of complications from the left atrial appendage occluder device. Number one is embolization of the device itself, which is very rare. And number two, they call it device-related thrombus, which is DRT. And the DRT management is by continuation of anticoagulation until the thrombus is gone. If the thrombus is gone, then you believe that there is actually a layer of endothelium covering the device itself, so the likelihood of having thrombus is going to go away. So that's the way how you need to deal with it. I would continue anticoagulation until I have another TEE report showing that there's really no thrombus. And the atrial fibrillation, the other device, the second device, the interrogation of the first device, don't really make any difference in your management.
Awesome. Thank you so much.
You got it.
So I think her second part with the device though, was that when Jamie went to interrogate it, still pulling from the old device and not the new one. So the second part of that is, does Jamie just have to re-interrogate and look for the leadless or?
So she can actually, and probably she has to interrogate the newer device. We may need to have the tablet to do that. But the new device, the leadless device, is hardly going to show you any AFib because it's single chamber in the ventricle. But the old device is going to give you information about the old. And I think you're right about checking the newer device just for the sake of it. They're extremely reliable devices and they should be fine. And probably she has to check. I guarantee you that they kept the older device because there's a fractured lead, but you're gonna get some information about arrhythmia burden and so forth, which is reasonable. I would do that too. The risk of taking the device out is extremely probably high. How old is she? 70, 80?
Yes, sir. I think she's around 80 something.
Right, yeah.
Hey, well, can I ask you another question as far as pacers go and some of these interrogation reports? Do you
Sure.
have like a standard, like, hey, this would be these are all the normal ranges versus, so when I'm reading these interrogation reports, how do you know exactly how to adjust meds based on, oh, it says heavy AFib burden. Okay, do I need to adjust their beta blocker if they're asymptomatic otherwise? Or like, how do I know that standard?
Well, we may need to come up with some kind of internal document between all of us to identify certain parameters in the device itself. Let me work on that. So when it comes to atrial fibrillation on devices, just very controversial topic, and you got to take it in a clinical context, and you got to take it in CHA2DS2-VASc score and so forth. Sometimes a couple hours of AFib, I don't anticoagulate. Sometimes half an hour, I anticoagulate. In terms of guidelines, anything above 24 hours continuous AFib, you have to anticoagulate. But anything below 24 hours, it's shared decision between you and your patient. Now, if you're dealing with patient who's elderly and who has high fall risk and probably chronic anemia and so forth, is it worth it to do something about it? I think we have to be careful about that. In terms of looking at the device itself and managing heart rates, I would rather go into clinical settings. In other words, I would go by vital signs more than the device itself, although the histograms of the device will give you an idea about, you're like that, and for the last month, your histogram is above your average heart rate, instead of being 60, became 80 or 90, you know, how much you have to manage about that. You're not managing the device itself, you're managing the patient. So is there any clinical association or clinical issues with your patient, worsening heart failure, worsening shortness of breath, and so forth, that you have to manage? But treating the device itself is not the way to do stuff. There's another thing. For instance, OptiVol and CoreView, if there's any accumulation, is that really reflective of that your patient is really accumulating fluids, or just the device itself, for whatever reason, maybe bronchitis, whatever, giving you this indication that there is a fluid accumulation? So I would take everything in clinical context, to be honest with you, and I would not really pay much attention, uh, a lot, into certain details like that. You have to know that your impedance is okay, threshold is okay, your sensing is okay. You have to know the battery life is okay. You have to know that the atrial fibrillation burden is not above, let's say, once you become 1 to 2%, you have to think about anticoagulation. You have to mention that. You have to chest vascular your patient. But certain minute details, I would take those in a clinical context. And you're really not your job in the nursing home to look into extreme details in patients, that minute stuff may not affect their quality of life much, to be honest with you. This is the way I see it. And if you look at the guidelines, actually, nowadays the guidelines uh, insist on individualized therapy and shared decision. You're going to see a lot of this: individualized therapy, shared decision. Your decision should be taken in a clinical context, in discussion with your patient, and so forth. There's really no doubt about the fact that medications are becoming very effective, especially GDMT nowadays. But can you do GDMT on everybody? Some of these patients may not be able to afford this GDMT therapy. Some of these patients, they may have UTI. You can do SGLT2 inhibitor. Some of these patients, they may have other complications and side effects that you cannot use these medications. So I would just focus on my patient. But this knowledge, and Tara, I'll tell you this, that your questions are extremely good questions, very good questions. You have to have a good knowledge as a provider, but at the end, you need to individualize your therapy based on your patient uh, factors, basically, and based on your discussion with your patient. How much can you offer to somebody who's 89 years old, demented, bedridden? How much? How much can you offer to somebody who's on wheelchair, demented? How much can you offer for somebody who's 69 years of age, cannot make decisions for him or herself because she used to be alcoholic, and now she's really moving very well, but she doesn't know where she is. I had the same encounter for patient, actually, not long time ago, that she is qualifies for ICD, but she could not make decisions. So even though I get paid as a physician, if I do ICD versus BiV pacemaker, but I elected to do BiV pacemaker, and it is what it is. I gotta stick with what's best for your patient. So again, individualized therapy and uh, shared decision, the way to do stuff.
That
Any other?
document you mentioned would be very helpful with interrogations. Just being new of
Oh,
what
yeah.
we need to include and like really focus on would be really helpful.
Yeah, absolutely. Based on the accent, who was talking?
It's Jennifer.
Uh-huh. Did you hear that? She knew you. All right. Well,
Out there.
I know. Dee is your friend. Did you hear that, Jennifer?
I did
Anyway,
my accent. I have an accent.
What?
no, no, in a good way. It's a lovely one. I used to stay in the South. Obviously, I have worse accent than all of you, but I knew that Dee will know you from the way you talk, which is lovely, by the way. Any other questions, guys?
I had one, Dr. Abraham, when you're talking about doing the TEE for the clot on the device, how long would you wait? Would you say 3 months, 6 months?
months.
How long of treatment?
3 months. There's no really guidelines about that. There are no guidelines about that. It's still something new for us, but I would do 3 months.
Okay,
I would-
thank you.
I would give 3 months for the clot to dissolve. We know these studies from, for instance, if you've probably dealt with left ventricular apical thrombus. We also used to wait for 3 months to reevaluate. So that's 3 months.
Perfect, thank you.
Welcome. Any other questions?
Last question that can be answered in like 2 seconds. Tara had a patient that was post-CABG, new CABG, was not ever on anticoagulation in the hospital, was discharged to the SNF, not on anticoagulation, but had AFib post-CABG, like most of them do. I told her to look at the operative note. Obviously, left atrial appendage clip has become really routine. She could not find that in the operative notes. So is it become so commonplace that they don't even comment on it on the surgical report anymore? Or like, should we anticoagulate them?
That's extremely good question. There's something entity called post-op AFib. And the post-op AFib, there's about 60% of these patients will go into atrial fibrillation in 5 years, and the rest will not. What I would do, I would probably anticoagulate for a couple months, reevaluate with telemonitor to make sure there's no recurrence, and then move on. So that's extreme, and I'm not sure if they knew. Probably they did not know about the AFib prior to the CABG.
No, it seemed like it was post-op.
Post-op, so there's really no indication, because the clip for the left atrial appendage is going to take about 15 minutes.
Yeah.
You have to make it a little bit away from the circumflex artery. Nothing without paying a price for that. There's a little bit higher complication if you do that. So routine management of that and routine placement is really not indicated. So what I would do, I would be very careful, and you gotta label that as post-op AFib. So everybody knows that, with the height of inflammation, the changes in the fluids, the left atrium is gonna get enlarged, and by enlargement, it's gonna start having wavelet electrical activity, and you're gonna start having AFib. That might not be an issue 3, 4, 5 months later. So what I do in my clinical practice, they are probably most of the time on amio. So don't
Yeah,
keep
she
them
was
on
on amio.
amio. I would stop amiodarone. I would wait for a couple weeks, 2, 3 weeks, get the heart monitor. If the heart monitor shows no recurrence of atrial fibrillation, I would stop anticoagulation. Yeah, I mean, not everybody. If you feel that there is maybe an indication of atrial fibrillation prior by talking to your patient, yes, but otherwise, post-op atrial fibrillation, it should be really managed as if the AFib may be coming because of inflammation, and we can forgive this patient for that episode and go from there. All right, any other questions? Okay. All right, guys. We'll chat in a couple weeks.
Thanks so much.
Thank you.
Thank you.
Thank you.
Thank you.